Prenatal bleeding during pregnancy, management and antenatal care. Prenatal bleeding during pregnancy include miscarriage, cervical pregnancy, placenta previa, placental abruption. Miscarriage. Miscarriage is the expulsion or extraction from its mother of an embryo or fetus weighing less than 500 grams when it is not capable of independent survival. These 500 grams of fetal development is attained approximately at 22 weeks, 154 days of gestation. In this scheme, I'll try to show the classification of abortion. Abortion divides into spontaneous or miscarriage and induced deliberate. Spontaneous abortion characterized by isolated and recurrent. Induced abortion divides on legal and illegal. Illegal is unsafe and may cause severe septic complications. Spontaneous abortion. Definitions of subcategories. Complete abortion, characterized by that all products, tissue of conception leave the uterus. Incomplete abortion, only some of the products of conception leave the uterus. Retained products may be part of the fetus, placenta, or membranes. Inevitable abortion, the cervix has dilated, but the products of conception can't be expelled. Missed abortion is a non-viable intrauterine pregnancy that has been retained within the uterus without spontaneous abortion. Recurrent pregnancy loss, defined as 3 consecutive pregnancy losses prior to 20 weeks from the last menstrual period. Septic abortion, a spontaneous abortion that is complicated by intrauterine infection. Treated abortion, a pregnancy complicated by bleeding before 20 weeks gestation. In this slide, you can see different types of miscarriage. Missed abortion. There is no vaginal bleeding, closed cervical os, no fetal cardiac activity, or empty sac. Treated abortion. Vaginal bleeding and cramping, cervix closed and soft, fetal cardiac activity is registered. Inevitable abortion. Vaginal bleeding and cramping, rupture of membranes, dilated cervical os. Products of conception may be seen or felt at or above cervical os. Incomplete abortion, vaginal bleeding, cramping, dilated cervical os, some products of conception expelled, but not all of them. Complete abortion, vaginal bleeding, closed cervical os, products of conception completely expelled. Missed abortion. Missed abortion is defined as unrecognized intrauterine death of embryo or fetus without expulsion of the products of conception. It is known more commonly as a missed miscarriage. It is also sometimes called a silent miscarriage. Etiology: infections, viral pathogens such as cytomegalovirus virus, herpes virus, parvovirus, and rubella. Genetic abnormalities. Cytogenetic analysis has shown that karyotypic anomalies are frequent and in missed abortions, with isolated studies reported that Up to 75% of causes had chromosomal disease defects. Idiopathic. The cause is not determined in about 60% of missed abortion, which implies other factors may be responsible. Various conditions, including hereditary thrombophilia, trauma, and autoimmune diseases, have also been implicated as potential causes. Epidemiology. Up to 12 weeks, overall incidence rates indicate that about 10 up to 20% of all pregnancies end in miscarriage, with the majority occurring during early pregnancy, up to 12 weeks. Rate among the all fertilized zygotes, extracorporeal fertilization IVF, are around 30 up to 50%. Risk factors. Age, more commonly more of 35 years, prior miscarriage, prolonged exposure to stress, abnormality in uterine anatomy, presence of adhesions or tumors, tobacco, alcohol, and or drug-abused women, progesterone deficiency, low body mass index, or obesity. Clinical presentation of spontaneous abortion. Missed abortion may develop without apparent bleeding and have an asymptomatic course because unlike because unlike the majority of miscarriages, the expulsion of pregnancy tissue does not occur. Like all other types of miscarriage, the clinical presentation of missed abortion usually involves bleeding, with spotting encountered in the majority of cases. Pelvic pain, which is commonly mentioned as one of the possible symptoms, has not shown significant association with missed abortion. Ceasing pregnancy symptoms, vomiting, nausea, physical examination. Missed abortion is characterized by manual examination per vagina, cessation of uterus growth, decrease in cyanosis of the cervix uteri, absence of cervical dilatation, vaginal discharge that turns from brown to bright red. Investigation. Ultrasonography is the optimal method. Diagnostic criteria. The absence of previously established cardiac activity of the fetus, usually in the fetus that has a crown rump length more than 5 millimeters, absence of fetal pole, beta-human chorionic gonadotropin levels will not fit the appropriate gestational age. This ultrasound image show in intrauterine gestation sac with an abnormality large yolk sac, 7 millimeters size. This is this is embryonic sac. Here is the embryon. The length is 6 millimeters, which is for 6 weeks and 2 days, and no cardiac activity. The pregnancy of 10 weeks gestational age, going by the date of the last menstrual period. However, the poorly developed embryo measures 6 millimeters in the size and shows no cardiac activity. These ultrasound findings suggest embryonic demise. Note, but by criteria, an embryo of more than 5 millimeters in size showing no cardiac activity on transvaginal sonography is considered to be non-viable case of embryonic demise. Treatment. All women must be informed of the advantages and disadvantages of surgical and medical treatment. For women who choose medical treatment, hospitalization is not necessary, but the follow-up period will be more important. Painkillers and antiemetics such as paracetamol and metoclopramide should be offered to them as needed. All women should be advised to contact the doctor in case of heavy bleeding or signs of infection. A follow-up visit is recommended to be performed within 2 weeks after treatment. Pregnancy test, physical examination of uterus, and ultrasound should be performed to confirm the status of abortion. In the event of failure, surgical management may be needed. Information and support must be given to the parents once they become aware that the fetus has died and in utero, as this can be a very traumatic experience. In most cases, the women request an early evacuation of the uterus. If a spontaneous miscarriage has not occurred within 28 days, the uterus should be evacuated because of high risk of coagulopathy. Missed abortion may be managed expectantly, treated surgically or medically. The decision about the mode of management should be based upon the individual's clinical condition and preference for treatment. Medical management of missed abortion includes the use of mifepristone in combination with misoprostol. It is recommended, or misoprostol alone. The treatment of missed abortion depends on having complications. If a woman has hemorrhage, sepsis, intractable pain, then the doctor have to make a surgical uterine evacuation. If not, then the doctor can make an uterine evacuation using hormone therapy. Surgical treatment. With around 95% success rate, surgical evacuation is regarded as the standard treatment for missed abortion, which had been widely performed all over the world in the past 50 years. However, the cost of surgery and hospitalization, as well as complications associated with surgery and anesthesia, are the major unresolved concern. Besides infection and bleeding, decreased infertility caused by intrauterine engagements may be unacceptable for women with missed abortion who haven't yet fulfilled her motherhood desires. Some studies have thus suggested that expectant or medical management might be more suitable instead of surgical evacuation. Here you can see the sonography pictures with cervical ectopic pregnancy. Cervical ectopic pregnancy is the implantation of blastocysts in the intracervical channel. The incidence of cervical pregnancy is less than 0.1%. Cervical pregnancy is a high risk cause because it may present with an accepted life-threatening hemorrhage, which may require hysterectomy to save the patient. Early diagnosis and non-surgical management with local and systemic methotrexate help to decrease maternal mortality and morbidity. Here you can see the uterus, intact uterus, and the cervix and gestational sac into the cervix. This is the same picture. Here is the uterus. Inside is a little bit liquid. And here is the gestational sac with embryo. The same picture, uterus, gestational sac, approximately about 6 weeks. 5 more clinically practical criteria which includes uterine bleeding without cramping, pain following a period of amenorrhea. A soft enlarged cervix equal to or larger than fundus. Products of conception entirely confined within and firmly attached to the cervix. A closed internal cervical os. A partially opened external cervical os. Placenta previa. Placenta previa is the attachment of the placenta to the wall of the uterus in a location that completely or partially covers the uterine outlet, opening of the cervix. Bleeding after the 20th week gestation is the main symptom of placenta previa. An ultrasound examination is used to establish the diagnosis of placenta previa. Treatment of placenta previa involves bed rest and limitation of activity, no sex, tocolytic medication, intravenous fluids, and blood transfusion may be required depending upon the severity of the condition. A cesarean delivery is required for complete placenta previa. Other complications of pregnancy can be associated with placenta previa, but the majority of women deliver healthy babies. The primary symptom of placenta previa. First, bleeding is the primary symptom of placenta previa and occurs the majority, up to 80% of women with this condition. Vaginal bleeding after 20th week of gestation characterizes placenta previa. Usually the bleeding is painless, but it can be associated with uterine contractions and abdominal pain. Bleeding may range in severity from light to severe. This slide presents the types of placenta previa, and they include complete placenta previa. Occurs when the placenta completely covers the cervix. Partial placenta previa occurs when placenta partially covers the cervix. And marginal placenta previa occurs when placenta ends near the edge of the cervix, about 2 centimeters from the internal cervical os. How is placenta previa diagnosed? The first is ultrasound examination is used to establish the diagnosis of placenta previa. Either a transabdominal using the probe of abdominal wall, or transvaginal with a probe inserted inside the vagina but away from the cervical opening. Ultrasound evaluation may be performed depending upon the location of the placenta. Sometimes both types of ultrasound examination are necessary. It is important that ultrasound examination be performed before a physical examination of the pelvis in women with suspected placenta previa, since the pelvic physical examination may lead to further bleeding. Treatment of placenta previa depends on, first, extent and severity of bleeding, second, gestational age and condition of the fetus, third, position of the placenta and fetus, and fourth, whether the bleeding has stopped. Cesarean delivery, C-section, is required for complete placenta previa and may be necessary for other types of placenta previa. A cesarean delivery is usually planned for women with placenta previa as soon as baby can be safely delivered, typically after 36-week gestation. Also, the emergency cesarean delivery at any earlier gestational age may be necessary for heavy bleeding that cannot be stopped after treatment in the hospital. Placental abruption. Placental abruption is when the placenta separates earlier from the uterus. In other words, separates before childbirth. It occurs most commonly after 20 weeks of pregnancy. Epidemiology. The estimated incidence is 1% of all pregnancies. Risk factors: preeclampsia and maternal hypertension up to 50% of cases. Previous placenta abruption, recurrence rate 90 up to 25%. Prolonged rupture membranes. Maternal pregnant woman for younger than 20 years or older than 35 years are at the greater risk. Maternal trauma, smoking, drug abuse, thrombophilia, amnionitis, short umbilical cord, multiparity, multiple pregnancies. Placental abruption is characterized by vaginal bleeding, surgical abdominal pain, uterine contractions and irritability, lumbar pain, maternal fetal compromise secondary to exsanguination, vomiting, vertigo, unconsciousness. Here you can see normal placenta and placenta abruption. Here is with hemorrhage, with bleeding, and here is internal bleeding. It is most dangerous. Placental abruption. Pathology, the exact etiology is unknown, but the final pathophysiology is likely to rupture of a spiral arteries with hemorrhage into the decidua basalis, leading to separation of the placenta. The small vessel disease seen in abruptio placenta may also result in placental infarction. Diagnostic: ultrasound. Complete blood count to evaluate the severity of blood loss. Here is placenta. Here is retroplacental hemorrhage. Here is also placenta and crescent of avascular lobe between placenta and uterine wall consistent with placental abruption. Treatment and prognosis. Treatment depends on the amount of blood loss and the status of the fetus. If the fetus is less than 36 weeks and neither mother or fetus are in any distress, then maybe simply be monitored in the hospital until a change in condition or fetal maturity, whichever comes first. Immediate delivery of the fetus may be indicated if the fetus is mature or if the fetus or mother are in distress. Blood volume replacement to maintain blood pressure and blood plasma replacement to maintain fibrinogen level may be needed. Vaginal birth is usually preferred over cesarean section, unless then is fetal distress. Cesarean section carries an increased risk in cases of disseminated intravascular coagulation. People should be monitored for 7 days for postpartum hemorrhage. Excessive bleeding from the uterus may necessitate hysterectomy. The prognosis of these complications depends on whether treatment is received by the patient, of the quality of treatment, and on the severity of abruption. Outcomes for the baby also depends on gestational age. Maternal death due to the placenta abruption are rare. Fetal prognosis is worse than material prognosis, and approximately 12% of fetus affected by placental abruption die. 77% of fetus that die from placental abruption die before birth. The remainder die due to complications of preterm birth. Thank you for your attention.